special guest, Michelle Bissell, who is a Parkinson patient, and she has agreed to volunteer for this session for doing the telehealth demo. So we're going to record and show. And then Tom, who's working with the video, hopefully he'll join us too. And we should be all ready to go when Tom is all linked up. Is he linked up already, Samyu, or not? Not yet.
I think we can hear him and see him, and he can see you, but I think he can't hear us.
Okay.
Could he still call in otherwise? Like
I need the meeting ID.
Oh, let me, can
Oh,
you
there it
Not
is.
entered any numbers. Please re-enter your meeting ID followed by.
Okay. Well, anyway, you can keep working while we get that straight out.
Entered any number.
maybe he can get the audio through the phone.
Right. We can do the audio through the phone if he wants to do that, rather than keep the video the same way. So, okay. So let's get going. And Nazar, tell me a little bit about, since we saw together last time, you came down with COVID, and very briefly, can you tell the audience what was it like in the first few days? What happened, and what made you feel like you have COVID?
So basically, you'll start feeling very, very tired and sort of malaise. Then comes the headache. So it was started on one of the Wednesday. I started feeling a bit unwell, but I didn't realize that COVID is going to come and catch me. Thursday evening only, I started having fever, which definitely, it was definitely a sign. Luckily, I didn't have much respiratory symptoms. So when you run around the hospital and always busy, you won't think that you are having COVID infection. So what happened is on Thursday evening, I started getting fever. Then I definitely went for a test, throat swab, which the result came on Friday, which was negative initially. But the fever didn't settle till Monday, till Sunday, which is another 48 hours after the result. So all my colleagues advised that I should have another test because there is about 33% false negative is there with the throat swab test. So I went for another test on Sunday. All this time I was having fever, malaise, and severe headache and body pain all over the pain. Pain is excruciating pain over the muscles. Then I realized I'm not having any sense of smell or taste. So that clinically confirmed my test before getting the test report. Then Sunday, I've given another sample. Monday, it came as a positive. So then onwards, I was waiting when I'm going to develop the respiratory symptoms. Luckily, it didn't happen. Then I took another 5 days for the fever to settle. After the fever started settling, I had a few bouts of cough for another 5, 6, 7 days, but that also settled. Okay. So it's about 2 weeks now. I'm back.
Right.
And started working. Yeah, I lost 3.5, 4 kilos within that 10 days.
Right. So that's lovely. I'm glad to have you back, and it's a delight to see you back back to work. So that's just wonderful news. I want to touch upon some of the things that you had shared with us as a part of our medical school group. And one thing that's particularly important for our group here, the Parkinson community, and we touched upon this in our previous webinars and Zoom sessions, is the notion that you fear the worst. You fear that death, impending death, or that possibly you're going to get so sick and you're going to die by yourself without nobody there by your side. That sense and how frustrating that was, number one. That's the first question. And what actions did you take? Like, for example, you mentioned that you called a good friend of yours and tell him where the will is kept and so on and so forth, that you want to share that. And what lessons can we take as we go along with this same idea as COVID continues? And we all know that probably COVID will have another session later in the fall, and maybe in the winter we'll have another bout of this. For us, especially the Parkinson community, the vulnerable community, what kind of things should we be doing in preparation for, that type of scenario? What are your thoughts?
So one of the things, I spend most of my time in the critical care, and 1/4 of my time in the theaters. So critical care, 10 to 20% of the patients die in the normal time, which is quite normal in most of the intensive care in UK. So when patients die, we know that they're going to die, and then the limitations comes in, and we allow them to pass away naturally with all the palliative care arrangements in-house, including we make a bit of a homely atmosphere for them to pass away with their near and friends and relatives and loved ones around the bed, which is an ideal scenario for someone who's going to die. The problem with COVID infections this is very contagious, and we can't allow bystanders or near and dear friends and relatives as a group into the intensive care unit. We allow only one person to come in. That too, we tell them the risks that what they're going to take, because they can get the disease from the hospital. Hospital is the best source of infection for these sort of patients. Whatever the precautions you take, they can get infected. So we allow one person to come in. Then once the patient has passed away, the body is removed in a totally different way. It's been cremated and all done by the specialized team which works around, and most of the family can see few video clips and things like that, rather than they can come and take part in the cremation and rituals and things like that. So that's one part. It's very sad thing, patients passing away without their own close relatives, friends and family around. So in COVID patients, about 50 to 90% of the patients I've seen around some of the units at 90% of the patients died. And some of the units, 50% is it's a very good outcome. In 50% patients surviving. In our unit, we had something like 48 to 52% survive, which is a very good outcome.
Yeah.
So these are in your back on your mind when you get yourself infected. Then your chances are 1 in 9, 1 in 10 to 1:1 for if you get into that stage. So you have to think about all your unfinished jobs, whatever the things like you may have some sort of commitments which has to be finished, financial commitments and social commitments. And it's nice to tell these things to your near and dear, or who you take as so my family is in India, and I'm alone in UK. So I got few best friends in the UK. So I was telling all these things to my friends. One of my best friend, what they should do if I get into the stage where I need respiratory support.
Right.
So that's one thing. Now, this situation is not going to end. It's going to continue. And it will take time for, say, either we have to have a vaccine or we have to have full test, identify the people with antibodies. Till that time, we have to be mentally prepared.
Right.
how to deal with these things.
Yep, that's right. So I'm glad you shared how you felt, and it's an object lesson for all of us that we can't wait for tomorrow. We need to think about it now. And if people haven't done things to plan, this would be a good time to plan, to put together do not resuscitate and things like that. If you have ideas around that, or to settle things, as you mentioned, like financial stuff and having will, a living will, so on and so forth, this would be a great time to set up all these things. And just to reiterate what you said, we had two other experts from the Parkinson's world who participated in our last call, Dr. Cheryl Waters and Pinky Agrawal. They said the same thing. It's like it's never late to do this and it should be done. But given this scenario, given that COVID is common and it's more fatal in people who are over the age of 60, who especially get the respiratory aspects of the illness, it's probably a good point to have all these papers done in a timely fashion. So I'm glad we had this discussion and we talk about it. Let me invite my colleague Vikram, whether he has any questions for you as a COVID survivor. We don't see a lot of COVID survivors, so I'm going to ask Vikram if he has any questions on it.
No, nothing. Thank you so much for sharing your experience. I'm glad you, through with COVID and everything, with it being such a scary thing, I'm glad you're doing well with all of that. But I don't have any questions as such.
Good, good. Any other thoughts, Nazar, before I let you go? Again, it's late in the night and I don't want to hold you back.
It's a pleasure.
Any advice, any thoughts, especially from a patient perspective? You've been a patient and a doctor, so from a patient.
No, I was very lucky. The COVID just touched me, smelled me, and left me alone. And I'm very, very glad, and I'm very happy that God has protected me.
Good.
Take the personal protection. Think always that next one who's standing near you is a carrier, and you need to behave like that. So I was very particular in taking all the PPE, and yes, I was involved in intubating and resuscitating and putting lines and things for COVID patients in the intensive care unit. And I was 100% sure I was fully protected with these things. But what's happened in my case is there were so many handover meetings and meetings with young people who there is a benefit of this. Two things. One is Black and Asians are very prone for infections, especially at the age of 59, 56, 60 years old is very prone for infection. But the young people are mostly the carriers, which these are the people who every day we mingle and we sit in the meetings and conferences and all the handover meetings. Then these young people may be the carriers, asymptomatic carriers. So my advice is, and I'm pretty sure I got it from one of these meetings which I was sitting in those things. So my advice is, next one to you, if it's within 2 meters, you have to make sure that he may be a carrier and he may get the problem. Yes. So that's my advice. Take the personal protection all the time. Yeah.
Great. Thank you so much. Let me also throw it up to the audience. Anybody in the audience have any other questions? I know I asked Vikram, but I see Tom and I see Cliff and I see Michelle. I see Tom Harris, Leslie. Anybody want to ask any questions? You're welcome to ask Nasir before I let him go. And then we're going to switch over to, anybody has any thoughts or questions? I guess.
I have one question.
Yes, go ahead.
I know I'm not in this, but since the recovery from COVID, did they automatically go and do an antibody test after that to see, like, if they can use the antibodies that were created?
No, it's not common in the UK. We are waiting for that to come. But the antibody test will be coming soon for the medical force, healthcare workers. Soon it will be coming.
Yeah.
So
Yeah, that's a good answer. Here in US, we have started doing this in our institution in Hershey. We are doing this now. We have a few COVID survivors from which we have collected plasma, and we have, as far as I know, we have transfused one patient with the plasma. Plasma donor has come through. We have collected plasma from, I believe, 20 survivors so far, and we have infused it in one patient. But it's, as Nazar says, it's very few and far between, and it's done in a research setting. So this is a research protocol, and they're getting this plasma as part of a research protocol. But it's slowly picking up. And as more and more people survive the disease, the higher the chance that we will have pooled plasma that will be effective for COVID. And the so-called herd immunity has to develop, and it's going to take time. And some of the younger people that Nazar mentioned, who would be asymptomatic carriers, they would develop the antibodies, and getting those antibodies will be very important in the future as we keep going in this pandemic, as we go along. But that will require more testing, and more people will need to be tested to see how many of them have IgG, and some of them will have IgGM positive situations. So, but again, thanks, Nazar. Please stay as long as you can, and
No, it's okay.
Yeah.
I'm working tomorrow morning.
Okay, super. Okay, good. Take care. Thank you very much.
Thank you.
Thank you.
Thanks. Okay.
So let's move to our second part of this thing, and we wanted to touch upon in this second session about telemedicine. So how Parkinson's disease has affected telemedicine, and what we can learn from each other, or how to do telemedicine visits, is what I want to share. And as a preamble, we are doing this already. And over the last 1 month, I have done well over 30 or 35 visits on telemedicine. It's been largely successful, but there are a few things that people still learning how to do. So this session, we are hoping to demonstrate how this can be successfully done, and what are the things that we needed. So for this, I'm going to ask Vikram and myself, both of us are going to demonstrate how we do this. So Michelle, if you don't mind coming close to the camera first, so that we can sit close to the camera, and Michelle is going to be our volunteer, so she's going to help us do this thing. Michelle, by the way, has been very gracious to be a volunteer for this particular session. She has had Parkinson's disease, and she's one of my patients. So she's doing amazingly well. As you can tell, hardly tell whether she has Parkinson's or not. And she's remarkably compliant, good patient. So let's pretend that I'm doing this for real. So this will be like, and so the first thing I would do is to say, hi, Michelle, how are you doing? Is everything going well? And you would say,
hello, I'm doing great.
Okay. And then the next thing I would do is to get your verbal permission for doing the session on video. Now, the reason why we do that is because the current rule that is set by something called CMS. CMS is an organization that controls how visits and clinical visits and doctor visits are done. CMS has demanded that there should be a consent for doing this on video or on phone. So I'm going to ask, hey, Michelle, can I get your permission to do this video session and for you to be billed for the visit like you normally would be from your insurance?
Yes, I give my consent.
Okay. So again, this is a pretend scenario, but this would be a typical thing that we would ask. And then the next thing we would typically ask is just to describe what's going on, how things are going. And we use the Unified Parkinson's Disease Rating Scale, UPDRS, or at least I do. And typically I ask the questions in the UPDRS. And the part 1 of the UPDRS is where we ask about thinking and memory. How's your thinking? How's your memory? Is everything going well? Any problems with that?
My thinking is good. My memory could be better.
Okay. And the other question that follows that is whether you have had lots of dreams and whether you hallucinate. So you have thought process problems is the second question we ask. Anything like that?
No hallucinations or anything like that.
Okay, and then the third and fourth questions are depression and motivation and initiative. So the third question is, are you depressed? Are you sad, upset, anything of that sort? And whether you have any motivation initiative issues.
No.
Okay. And then we go to what we call the ADL side of things, which is activities of daily living. And that has a set of several questions, and it has to do with simple things. And I won't go through all of them for the sake of brevity of time, but I'll just share a few ones. For example, we ask, are you able to feed yourself? And the answer is
Yes.
yes. Are you slow in your feeding? Have you become slow? Have you have more difficulties with feeding? No.
No, I haven't.
Okay. And another example is whether you have any difficulty with dressing, putting on small buttons, jewelry that requires dexterity. Do you have any trouble with that? Do you ever ask anybody to help, your daughter, your husband to help you?
No.
Okay.
It becomes slower, but I haven't had any help.
Right. So this goes on, and there's a bunch of questions in there, and it also goes about tremor. We talk about hygiene. We talk about speech. We talk about swallowing difficulty, and so on and so forth. Those are on the questions. Those are the set of questions that typically ask. Again, I won't go through all of them. And then we get to the part where we do the Unified Parkinson's Disease Rating Scale motor testing. So this is the part where we need to examine the patient doing different things. And for this, I'm going to ask Michelle to go sit in the chair, which is placed approximately 10 feet away. Is that correct, Michelle?
Yes.
Okay. It's approximately 10 feet away. Maybe you can come a little bit forward. Yeah, that's good. That's good. And the way we position this, as everybody can see, we want to capture a whole of Michelle from her head all the way to the feet so we can see everything that she's doing. So we want to capture all of that. And typically we ask the patient to put both hands out like this, spread it out, yeah. And spread it out slightly to the side, yeah, okay. And then with the eyes closed, take the pointer finger, touch your nose with the right hand, and then with the left hand, okay. And now with the right hand, you're gonna open your eyes and you can put your hands like this, and you wanna tap as big. And then the same thing with your left hand, tap, 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 tap. Now, sometimes it's helpful to turn the hand to the side so that the little circle that you make is against your blouse, for example, so you can see the contrast against your blouse a little better. So slightly lower, Michelle, slightly, yeah, right there. Like you can see the contrast better. And when you do it this way, with the circle pointing to the side, and like I have it, it might be sometimes harder to see it, right? Okay, so that's another trick that we may ask people to do for that particular test. And this test, we need to do this for approximately 10 iterations. And again, big and wide, as big as possible and as wide as possible is what we do. Right? Vikram, you want to add anything to what I just demonstrated? You want to?
So a few other things that we might also test is have patients go like that with your arms. So hold your arms out in front and go like that. Flip your arms, flip your hands back and forth.
And you should do one hand at a time. So do right hand, back and forth, like you're catching raindrops, putting it down, catching raindrops, putting it down, one hand, and then do the other hand.
Mm-hmm.
Okay. Keep going, Vikram. Yeah.
So that'd be one. The other thing which we can certainly test for is also your gait. So for example, what we would have you do is like cross your arms and stand up with your arms crossed. And then you would put your arms down, and then we would just see you walk back and forth.
Walk towards the camera and turn around and walk back to the chair. And just to see a little bit more, can you move the chair away and walk all the way to the door in the back? So what we can see is the reduced arm swing when Michelle's walking. So you can see that one arm swings more, the other arm doesn't swing as well. Can you walk on your tiptoes? And walk on your heels? And turn around and walk like you're walking a tightrope, one leg in front of the other. And turn around. And jump up and down 10 times. Okay, stand on one leg. Stand on the other leg. Spread your legs apart a little bit. Bit more. Slightly separate your legs. And squat down and get up like you're a baseball catcher. Hands like this. Put your hands up like this. Don't fall now. I don't want you to fall.
On that one.
Okay, good. Okay, come on back up. Okay, put the legs together and close your eyes. Excellent. Okay, very good. And you can pull up the chair a little bit forward because the chair is on the sunlight. So move it slightly forward. Yeah, right there. Yep. And have a seat again. Have a seat again. And two other tests that we typically do is the foot tapping test where you heel strike. Actually, your leg is off the camera, so move back a little bit. Yeah, bit more. Yeah, stop right there. Yeah, stop right there. And with your right heel, you're going to pull it up and stomp. Yeah, like that. Yeah. Yeah, keep stomping on the ground as fast as you can go, 10 times. And with the left leg, the same thing, 10 times. And the one thing we didn't do is the you can stop doing that. Yeah, the right hand, make a fist, open fist, open fist, open fist, open fist, open fist, open fist, open. Left hand fist, open fist, open fist, open fist, open fist, open. Okay, so this is pretty much all the, yeah, and we're good there. So I'm gonna ask your husband to help here. So sir, can you come and assist in this rest of this exam? So I'm gonna have you go next to Michelle and I'm gonna have Michelle stand up. Okay, and face this way to your left. Go to your left. Okay, okay, so to your right then, sorry. Go the other way, yep, yep, stop right there. And sir, you're gonna stand behind her and you're going to catch her by the shoulder in the front. Yeah, and you're gonna try to tip her backwards, just gently. Don't do it too much, just a gentle tip, okay? You have to catch her if she falls, okay? It's your job to catch her, so, okay? Okay, so just a gentle tip, yeah. And can you go a little faster? This is a pull test that we do just to see how the balance is. There you go. Okay, perfect. Okay. All right, that's good. Thank you. Thank you for doing that. And okay. No, that's not part of the test. So, okay. All right. So again, that's a way in which we will use, for example, somebody in the household to help us do the exam. And then we might ask questions about other side effects of medications and so on and so forth. So again, I'm going to ask my colleague Vikram to ask you a few questions about your medicines and what we would normally ask. Yeah.
So like, what dose of medicines are you on right now? How often do you take?
I am taking the carbidopa, levodopa, the 25/100. And I take that 4 times a day.
Perfect. And have you had any side effects such as nausea, vomiting, any hallucinations, lightheadedness or dizziness, any of those side effects with the medication?
No, I've been really good with it. The very first time I started taking it, I had some light nausea the very first time that I took it, and that lasted maybe a week and a half. After that, I've had no side effects at all.
Perfect. And have you been generally compliant with your medications, taking it every day, 4 times a day?
Oh, yes. I have alarms set on my phone, and when my alarm goes off, I take that medicine religiously.
Perfect. That's awesome. Are you on any other medicine other than the carbidopa, levodopa?
Yes, I take the Rizagiline, and I take that once a day in the morning.
All right. Perfect. All right.
And any other things, Michelle, you would bring up let's pretend this is a real visit and you're seeing both me and Vikram. You get 2 for 1. Okay, so you get 2 doctors. So what kind of things would you raise? And let's pretend it's a real life visit.
I would say my biggest issue with the disease so far has been fatigue and lack of sleep. I go through days where I feel great, and then it'll hit me where I don't sleep at all, where I'll be up for like 24 to 36 hours, and I just cannot sleep no matter what I do. I do take melatonin that you prescribed or had suggested that I take. So I do take the melatonin, which does help most of the time, but there are days where you just cannot sleep at all. And just the daytime fatigue is just something that I think you just got to learn to deal with and try to figure out ways to keep yourself going.
And again, would you describe for Dr. Shivkumar, Dr. Vikram here, how often does this sleeplessness happen? Is it once a week? Is it more than once a week?
I would say it's probably maybe 4 to 5 times a month.
4 to 5 times. So roughly about once a week you get this.
Oh yeah.
Ballpark, yeah. Okay. All right. And despite taking a good dose of melatonin, you're taking almost 10 milligrams or 9 milligrams, whatever, you're still not getting the full benefit for consistently, right? Right. And we have discussed adding clonazepam or Klonopin, but we decided not to do that because you didn't want the side effects of sleepiness, the excess daytime sleeping.
Right.
We've chatted about that, right? Again, what is your perspective, and this is a slight change in what we've been talking so far, about doing the telehealth visit, this visit that we're doing right now, from a patient perspective, from looking at it from a patient perspective, how is it different doing it this way as opposed to when you came into the office for a visit where you saw in person the doctor? What's your feeling about it? Talk to us about it.
For me, I prefer to go in and see the doctor. I'm more of a on hands kind of, I like to be there in the office, but I don't mind the teleconferences because as long as I can see the doctor and see the reaction and know that I can talk to him, I'm okay with that because I can still see you and talk to you, whereas a telephone would just be completely different. But knowing that I can see you and you can still understand what I'm saying and we can still communicate, I'm okay with that. As long as I know what I'm doing, how to set up the computer. I mean, that's going to be the biggest hurdle is.
Yeah, can we talk about that, and please invite your husband to join us here. So, because I know he's very computer savvy and he's in the computer world, so he's welcome to join here.
Yeah, I can go further.
Yeah. So, sir, I mean, again, for you, it's fairly easy to set up Zoom calls because this is part of what you do.
Yeah.
And so it's easy for you to set this up. And I'm sure probably if he asked you to set up something else, some other platform, Skype or whatever, it would not be a big deal because you're there for it. But again, putting your hat of Michelle, pretending you're Michelle for the moment, and any other people who don't have your skill set at home, what kind of advice would you tell? So again, this is for the general audience. What kind of things can you teach?
I think from your side of things, if you want less tech savvy people to be able to do something like this, it's very easy if there are detailed instructions, and I'm talking detailed instructions to the point where you might even want to take screenshots of each step and have it something, and then like maybe put it like in a PDF file or something printable that they can, if they have printers, that's another thing, but something where there's pictures so they can see what they should be seeing. Because that's going to make it the easiest way possible. Because, personally, with my job, I'm dealing with a lot of individuals right now that are attending online worship, And the biggest hurdle is for those that aren't Facebook users to jump in and attend. So recently we've laid out step-by-step picture instructions that we put up on the website, like here's what you're going to do.
Gotcha.
Because our less tech savvy people can at least get to our website and look up that information.
Gotcha.
So
point. At Marshall, we've been using Microsoft Teams for our telemedicine visits. And for the first 2-3 days, it was quite a bit of a nightmare for us to figure it out on our end as to what we were supposed to do, and patients were having trouble figuring it out. So that's actually what we ended up doing. After a couple of days, we sat down and made screenshots step by step for Android, for computers, as well as for Apple, for iOS phones, for patients to see what they were supposed to click on and what they would see at each and every step. And that certainly helped a lot.
So did you actually send a paper copy to people, or what did you do?
So Microsoft Teams uses email. So what we would basically do is we would send them one email, which would have the invitation to the meeting, and another email right after that with the instructions on there.
Right, but again, the point Mr. Basal was telling us was that they may not have a printer. And so then if they don't have a printer, they have to look at it online and see. And if they're not tech savvy and they don't know it, then they may not, you can send all the instructions, but you can't read it, and there's no point in it. So maybe paper copies in the mail, maybe that would be worth it. I don't know. So something to think about. So again,
something that we weren't able to do is might certainly be a good option for the future, but given the time constraints now, where suddenly everybody had to start adopting telemedicine, getting those things sent out, because first we had to contact patients and figure out if they were going to do telemedicine or not.
Right.
But had the means. For example, where I am in West Virginia, a lot of people don't have internet connection, let alone having smartphones or computers. They don't even have internet connection, so they might not they might not have any way to do this at all.
correct.
So, but certainly, as you said, having like paper copies might certainly help patients understand what they're supposed to do.
Right. One last thing before I let Michelle go and we go to Tom, assuming Tom is all hooked up now. I don't know if we're still, Sam, are we hooked up with Tom yet or no?
I think we are. We're going to have to figure out audio.
Okay.
We'll see when we...
Okay, all right. So before I let Michelle go, I want to have Michelle do one last thing. And for this is eye movements. So we're going to test your eye movements. Now, we don't do this routinely on everybody, but sometimes we have to. And for this test, I need you to come as close to the camera as possible with your eyes, just like I'm doing. And then you're going to look all the way to the right, like I'm doing, and all the way to the left. Yes. And then all the way up as high as you can. And for the last test, I need you to hold your eyelids open with your both hands, like I'm doing. Eyelids open. And then I need you to look down, all the way down as possible. Great. Okay. And then the last part, that's done. You're finished. Now you're going to make a big smile. Look straight at the camera. Yeah, there you go. And you can open your mouth real big. And lift your chin up a little bit. Yeah, and stick your tongue out. Okay, perfect. Beautiful. Okay, that's it. Okay, thanks again, Michelle. You've been a great trooper. Thank you for allowing us to do your exam, and be well. Thank you very much. And I'm going to let you go if you wanted to go. You're welcome to stay. If you wanted to stay a little bit longer, you can. But if not, you're welcome to come off at any point. Thanks again. Appreciate it.
Thank you, everybody.
Yeah, welcome.
Good night.
Yeah, bye. We lost Tom, I guess. Where is Tom? So I hope he comes back. Is he just stepped out, or do you know where Tom? Some of you want to find Tom?
Yeah, let me give him a call.
Probably. So there's a few other things that in my practice we came across as well.
Mm-hmm.
on the topic of like when you were mentioning that we ask patients as to if they have any particular issues they want to talk to, might not be a bad idea for patients to also write down in advance as to what topics they want to talk about. We advise that in office visits as well, but especially in a telemedicine visit where they might not have family with them, or telemedicine visit. And secondly, like for example, in an office visit, even if you're on your way out of the door, you remember something you can ask. But once you hang up the telemedicine video visit, there's no going back.
Yeah, yeah,
So
yeah.
having a list will certainly help.
Yeah, that's great. Well, we have Tom back here. Let's give it a try to see whether we can examine Tom also. Tom, can you hear us? Tom, are you able to hear us?
Are you able to hear us, Tom?
I can.
Okay. Can you put both hands out like you're Superman in front of you? Yeah. And with your right pointer finger, touch your nose. And now do it with the other hand. Okay. Open your eyes. With the right hand, can you tap, tap, tap? Do this.
Sue,
With your right hand, can you tap? No, against your body, Tom, against your body. Yeah. A little bit forward. A little bit forward. A little bit forward. Okay, how about with the other hand? The other hand. Okay. And with your right hand, can you do this?
I have to get a little closer, Sue, but I don't have a picture.
Okay, how about the other hand? Okay, stomp on the ground with the right leg. Now with the left leg. Good. Okay. Can you set your phone on the floor? Okay, and cross your hands this way. And try to get up without holding to anything. Good. Okay, that's great. That's great. Okay, have a seat again. Okay, can you hear me?
Yes, but it's not real good.
Okay, okay. Do you have dyskinesia today?
No,
Okay,
not that I noticed.
okay, okay. We noticed some. There is some on your toes and a little bit of body swaying that I can see. Not a whole lot.
Yeah, that's always there.
Okay, okay, okay. And what kind of problems are you having with connecting on the audio?
Pardon?
What's your trouble in getting the audio connected?
I'm not sure. I don't think I have a microphone.
Well, we
on
can
my,
hear you.
Computer.
Okay, we can hear you very well.
Okay.
Yeah. So not sure why it's not working, because you said you are able to talk to your grandchildren, right?
Yes.
What do you use for that? What system do you use for that?
Oh, we use one of those Google boxes.
I see. Okay. It's not the computer. You don't use your computer for that.
No.
Okay. And you can't use FaceTime either. You can't use your phone either.
We probably can. I've never done it.
I see. Okay. Any thoughts on that you want to share with me or Vikram about what's going on right now? How do you feel about this visit?
Glad to participate.
Yeah, I know, but there's a challenge here, right? Because you can't use the technology well.
I don't know. I guess I don't have that gene.
Yeah, okay. No, I mean, if you were to give an opinion that this were to become common, that we had to use this all the time, how would you feel about it?
Well, I think it is very efficient.
Okay.
Dr. Subai, I spent 12 years on a hospital board, so I understand a little bit of the economics of medicine.
Right. I mean, there's clearly economic advantages both ways, because if patients don't have to travel for their visits, that would certainly save a lot of aggravation. And also the brick and mortar costs for hospital visits are quite significant, as you know. So there would be lots of savings. And I and Vikram were sharing this morning. We were talking about this, how if telemedicine came in, it would change healthcare, and it would change significantly for a lot of these visits. There would be cost savings, and in many different ways it will change. But also the convenience point, where you're not able to touch and feel the patient, shake hands, you know, and have a personal one-on-one contact. How would you feel about that? What's your thoughts about that?
Well, you know, something has to give in healthcare, because we can't continue the way we are. We're not going to do every visit electronically, but it'll create a significant cost savings to do some of them.
Right.
And that means that, you know, we'll have, the industry will have money to spend in other places.
Right.
So, you know, something has to give. We don't want rationing. At least we're told we don't want rationing. And I think cost-saving measures like this will, you know, maybe alleviate the need to do rationing.
Right. I couldn't agree with you more. I think it's a great thought. I think it's a great way to think about telemedicine, that the upside of COVID, that we actually have some benefit like this would be a great thing. Yeah. If there is an upside to COVID, you know, it's not like we really want to do COVID because of this, but I'm glad that it happened. So,
well, I think it's forcing us into what we should have been doing some time ago.
Right. Agreed. Vikram, your thoughts? We can kind of wrap things up here. So, we need any other thoughts? Do you want to ask anything to Tom?
No, so I agree. Certainly, there's lots of positives to this. One thing, you know, is what he brought up with regards to the technology and everything. Maybe encouraging patients to have, if there's family members or somebody else who could help out, for example, might ensure a greater likelihood that patients can speak to the physicians. So that would certainly help.
Yeah.
And you know, sometimes even for us as physicians, when you're trying to use these platforms, might not be appropriate for ourselves. Like, for example, what I did in our practice here is I made a dummy account for myself as a patient. So then I sent an invite to myself, and that way, as I clicked through that, then I could figure out as to what kind of roadblocks might be there for patients to go through. So then it helps us troubleshoot better as well.
Right.
I certainly agree with both of you that this is certainly something which hopefully we'd be allowed to use much more in the future after the whole COVID pandemic resolves as well. It certainly got a lot of benefits, especially in situations where patients are traveling for over a couple hours for their office visits. It makes a lot of sense to have this be much more a part of routine care rather than just an emergency tool.
Right. Great. Fantastic. Samyu, any questions that you have gotten from anybody about anything that you want to bring up?
No, not particularly. I do know that I've been calling some of our patients just to, you know, check up on them. Mm-hmm. And a big thing does happen to be just navigating the whole like video conferencing, be it for telemedicine or just contacting family and friends. I know with the whole stay at home extending, more and more people are, you know, it's time for them to actually have their doctor's visits, and they are having to do televisits. So it's definitely something that is coming. And like you and Tom and Vikram, like you guys mentioned, it's good that we kind of use this as an opportunity to kind of get familiarized with it. And maybe we should come up with some sort of like paper form and also in electronic form. Maybe even, you know, those YouTube tutorials where they like go through the action and screen capture the screen, something like that. So people have a way to kind of
see what's there.
See what's there. And then all the little like troubleshooting that might need to happen, because I think the hardest part isn't just installing, it's when it doesn't go as you expect it to. The little hiccups, when they come, you end up with like a roadblock that you just don't know how to get past. So I think it's definitely important.
Good. Yeah. So do you want to open up the all the people who want to ask questions? Anybody else has any questions for Tom? Any Cliff is there. I think Judy Berger's there. A couple of others are there. Anyone have any questions for either Vikram or for Tom? Anyone has any thoughts? And Tom, do you have any closing thoughts on, you know, this session? Is this kind of a session a good one? Is there? Do you want to get closer so that we can see you closer on the screen? Yeah.
Well, as you know, Sue, I'm 2 hours away. So that's 2 hours down, 2 hours back, probably another hour to get there 30 minutes early. Wait in the waiting room, there's lunch. It's a whole day.
Yeah.
And we're professionals and we understand if we want to take a day off, we can do it. But if you're a construction worker or I could name 24 occupations.
Yes.
They don't have that flexibility.
Yes.
And they're probably their care is probably lacking because their ability to reach out to you is maybe a half-hour lunch break.
Right.
And they're trying to call into you.
Right.
And as a result, I think those folks end up on the short end.
Yeah.
So with electronic visits, I believe that maybe the people that don't have the flexibility we have are going to you're going to be able to give them better care.
Agreed. I think it's a great thought and wonderful thought. Thanks again for spending this very good evening with us and allowing us to do this exam and using yourself as a demonstration for how to do this exam. Thank you very much, and having everybody here. Thanks for having me. Yes, Cliff.
I think on the, what did I say?
Hello.
Hi.
Cliff was just saying he personally still would prefer a live visit.
Yes.
I said, I think you should share that.
Yes, absolutely.
I come from being in practice too. I would have preferred it that way.
Yeah, I think there are lots of advantages to seeing somebody in person. There's a personal touch, the doctor-patient relationship, and the chance to kind of see and touch and feel the sensations beyond just the visual and audio. There's handshake and, the chance for us to, mingle and, have multiple people. And there's a proximity is there. So there are some advantages to it, but also, as Tom was saying, the reality of social distancing, how that is important in this day and age. Even with the best PPE, you could wear all the protection, as Dr. Nazar was saying, and you're still worried whether you would get the infection or not. And at a vulnerable age, when you're in the 60s, 70s, and 80s, which a lot of Parkinson patients are on, can we get away with doing it without actually making a physical visit? Can we do it? And can we get as much possible? I know the mental satisfaction, the emotional satisfaction may not be there, but can we do the medical business without putting people at arm's way? That's the question, right? So as Tom was saying, maybe not all visits would be there, but some visits, maybe do a visit every 6 months, but if there's in between something that comes up, maybe a telemedicine visit would be a shortcut to having you come back more frequently. So,
well, and folks, I'm Cliff's wife. In our case, Cliff did have an appointment where they called with feedback. It wasn't, neurology. I had to be here taking notes, or he would not have retained what the message was.
Right. So I think the option in the future, maybe recording these things. So if we can record it, then that would be great. But again, maybe not. Maybe now we can do it, whatever. But recording it, having it available so that he can see it again and then listen to, what did they say? You know, so it's remembering. So, and yeah, yes, Tom, yes.
There's a very significant plus to doing these electronically, and that's perhaps you've adjusted a patient's medication. The patient says, well, you know, it's not working. And you've done this with me, and I sense your frustration in trying to get a mental picture by me verbally telling you what's going on.
Right.
And there's probably some room for error there. I remember the first time I visited you, I came down to Hershey, and a week or two later, I was speaking with your nurse and describing some things, and you said, I want to see you back.
Right.
With a new patient, and you were very concerned. That trip could have been eliminated by 5 minutes in front of the camera.
Yeah. Yeah, you're right. I mean, a picture, they say, is worth 1,000 words. Video is probably worth 1,000,000 words or even more. So you're right. I think the other Tom had a question. Sir, you're muted. You want to, your microphone is muted. Do you want to unmute? Yeah, go ahead. Yes.
I wasn't controlling it.
Oh, sorry, it was me.
Yeah. I was impressed with the definition and the resolution of the camera.
Okay.
I was wondering if it would be good enough for you to see and analyze from it, and it obviously was. I think there's a lot that can be done by this media.
Yeah. It's actually pretty good. We can see you really well right now, and pretty impressive, actually.
The thing that I was really wondering how you were going to do was the tap, 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 tap.
Yeah.
Those sort of things where
the
resolution had to be good enough for you to see the variations.
Yeah.
But I was impressed, and I think there's a lot of possibilities for certain patients in certain instances.
Yep. Thanks again. That's a great comment. Thank you for that comment. And I hope this is a good illustration of how things are going to be in the future. And I think not for everybody, not for every visit, but some visits, I think. Yeah.
Thank you.
Oh, thank you very much. Well, thanks everybody for joining. And again, thanks Vikram, and thanks Tom and others who joined us. We appreciate it. And take care. Have a good evening. See you all. Bye-bye. Bye.